Thank you very much, and thanks for this very kind introduction and also for the invitation. I'm really happy to speak tonight or this afternoon. So first, my disclosures. These are not really relevant for the topic, but in any case. So I will be speaking about my favorite topic, cartilage-hair hypoplasia. And first, I'll just briefly discuss the spectrum and classification of monogenic bone disorders, and then how cartilage-hair hypoplasia fits into this classification. Some thoughts about history of cartilage-hair hypoplasia, and then I'll be focusing on genetic features, clinical manifestations, and immune deficiency and its consequences. So regarding the spectrum and classification of genetic bone disorders, so we know that skeletal dysplasias are rare genetic disorders of the skeleton, and they are usually monogenic, meaning that there is a single mutation in a gene which has a major role in skeletal development, and this then leads to abnormal patterning, growth, differentiation, or maintenance of the skeleton. And presently, more than 700 different forms have been recognized. And the phenotypes are very variable, as you can see here. This is a Finnish team participating in the World Championships for individuals with short stature. And this was actually a really winning, successful team, bringing back home many medals. But you can see the phenotypic variability in these individuals with different types of skeletal dysplasia. So to put these disorders into some kind of order, there is this nosology of genetic skeletal disorders, which is revised every 5 years, and the most recent one is from 2023. And this lists 771 different disorders, and they have been divided into 40 different groups, defined by radiographic criteria, molecular or biochemical features. And here on the right-hand side, I'm listing just some of these groups, and cartilage-hair hypoplasia belongs to this group 11 of metaphyseal dysplasias. So metaphyseal dysplasia means, let me take my pointer, means that the main features or abnormalities are in the metaphyseal region of the long bones. Epiphyseal dysplasias involve the epiphyseal growth plates, and then in some skeletal dysplasias there are spinal abnormalities leading to the spondylometaphyseal, spondyloepiphyseal, and spondyloepimetaphyseal diagnosis. And I have some radiographs just to show what are the epiphyseal dysplasias. The epiphyseal plates are abnormal. They are small and irregular in shape and size, sometimes completely lacking. And there are, within this group of epiphyseal chondrodysplasias, there are multiple genetic forms of multiple epiphyseal dysplasia or spondyloepiphyseal dysplasia. And as I mentioned, cartilage-hair hypoplasia belongs to this metaphyseal chondrodysplasia group. Here in the middle, you can see radiographs of a patient with cartilage-hair hypoplasia, broad and irregular metaphyseal parts of the long bones, especially in the knees, but also somewhat in the hips, irregularity here. Whereas in this other type of metaphyseal chondrodysplasia, Schmid type, caused by mutations in type 10 collagen, the findings are also confined to metaphyses, but these are a little bit different, maybe not as irregular, and especially these patients usually have this significant varus deformity at the hips. And Schwachman-Diamond syndrome is then another metaphyseal chondrodysplasia. So we then go to only cartilage-hair hypoplasia, or CHH. Some words about the history. And I think the first cases were actually described in 1963 in France by Professor Pierre Maroteau. But the main work was done by Professor Mäkitie when he was studying dwarfism in the old order Amish population. And it was known that this is an inbred population with remote consanguinity and lots of autosomal recessive disorders. And in his studies, Victor Mäkitie identified two new autosomal recessive skeletal disorders among this population. The other one was Ellis von Creveld syndrome, and the other one was cartilage-hair hypoplasia. And actually, already in 1965, Victor Mäkitie had a really detailed characterization of the disorder, and it was also called as metaphyseal chondrodysplasia type Mäkitie. So he showed that it's an autosomal recessive condition. The patients have severe short stature. They often have sparse hair, which was not seen in other forms of skeletal dysplasia. And they had joint laxity, especially in the fingers, as shown in his original photograph. But they also had often this elbow contractures, so they were not able to completely extend elbows, and some other features. But already at this point, he speculated that the patients might have some form of immune deficiency because there were some early deaths and especially severe varicella among the affected individuals. So we've learned quite a lot about the radiographic features, but it is really a metaphyseal chondrodysplasia, quite significant changes, especially in the knees, in other metaphyses as well. The knees are more affected than hips in almost every single case, but the long bones are also short, and also the fingers and toes and feet are short. The patients have normal skull, and there are no major changes in the spine in most of the cases. So cartilage-hair hypoplasia is also very common in Finland, and this is based on maybe a little bit similar history as with the Amish people, that it is a very isolated population even nowadays, and this has led to these remote consanguineous marriages. Close consanguinity is not happening in our country, but the remote consanguinity is because of this small population. And so this has led to accumulation of over 30 autosomal recessive diseases in Finland, and these are called collectively the Finnish disease heritage. And these disorders actually include 3 different skeletal dysplasias, and cartilage-hair hypoplasia is one of them, and then dystrophic dysplasia and Muli brain nanism are also parts of this Finnish disease heritage. And on the map, you can also see that there are some like regional accumulations of the patients' ancestries. So nowadays we know that the overall prevalence of CHH in our countries, we know of more than 150 patients in a population of approximately 5.5 million. Among the Amish, I'm not quite sure about the exact number, but more than 200 subjects presently. And then cartilage-hair hypoplasia has been seen in most of the populations, but it seems to be very rare in other populations. So after Mäkitie's description, we've of course learned quite a lot, especially about genetics of the disorder, but also new information has come up from the clinical studies, and we now know much more about these different features. Unfortunately, my time is limited, so I need to finish before midnight finish time. So I will not be able to cover everything, for example, Hirschsprung disease, but I'll do my best to focus on the most important things. So the genetics is very interesting in cartilage-hair hypoplasia. Based on the Finnish families, the CHH gene was localized to chromosome 9 already in 1993 by linkage analysis in 14 Finnish families. But then it took 8 years to really pinpoint the gene itself, and the gene turned out to be extremely interesting, and the discovery was published in Cell in 2001. And it was interesting because this RMRP gene, it's an RNA molecule and component of this RNA's MRP complex. So it's an RNA and it's untranslated, so there is no protein. And it's also very small, only 300 nucleotides, and belongs to these long non-coding RNAs. And it was actually the first non-coding nuclear RNA gene implicated in any human disease. The figure here shows the RNA molecule, RMRP, which is bound to these different proteins and these complex functions together. The function is not completely understood even today, but it seems to have multiple functions, for example, in ribosomal RNA processing, in cell cycle control, and interaction with the telomerase catalytic subunit. There is one major mutation. This is the main mutation. I've marked it here. in the Finnish population, but also in the Amish population, and it's common in all the other populations as well. But there are several different mutations along the RNA molecule linked to cartilage-hair hypoplasia, but also some mutations have been linked to a little bit different phenotypes, for example, metaphyseal dysplasia without hypertrichosis, or anoxic dysplasia, or Omen syndrome. And there seems to not to be any clear genotype-phenotype correlation, and as you can see, the mutations are really dispersed throughout the gene. But there are also very many mutations in the promoter region of the gene, and these are usually compounded with another intragenic variant. And to my knowledge, there are only 3 cases where there is a homozygous promoter region mutation in cartilage-hair hypoplasia, and this is one of the most recent descriptions, describing one patient with extremely severe cartilage-hair hypoplasia, and she was homozygous for this promoter region duplication, and the parents were carriers, and here they also showed that the quantity of this RMRP transcript expression was completely abolished, maybe explaining the severe phenotype. So regarding the different functions, I will not go to very much in detail, but some words about this. This is a recent publication studying this RMRP effects in fibroblast, and especially focusing on ribosomal synthesis. And their conclusion from this study was that CHH seems to be a ribosomopathy, that there is a disorder or abnormal ribosome synthesis, and that more studies are definitely needed to go into details in this aspect. So it's a fairly recent publication and further studies are hopefully coming. Then we have also studied how CHH affects the telomere lengths. It's been shown that this RMRP interacts with the telomerase complex, and we then wondered whether these mutations somehow have an impact on telomere length. And for this study, we collected DNA samples from 48 patients with CHH, 86 first-degree relatives, so most of them were mutation carriers, and then healthy controls. And we could show, as you can see here in the figure, when we divided the individuals to children, young adults, and adults, that especially among the children, the patients had shortened telomeres, but this was not so evident in the young adults and adults, and it's a little bit difficult to explain how this could be, but one explanation could be that the ones with shortened telomere lengths have poor prognosis and had already diseased and are not the survivors that were included in this study as older adults. But there seemed not to be very clear correlation with the clinical phenotype, and we don't really know the significance at this point. Then we've done studies to see or transcriptome analysis and focusing on cell cycle progression in cartilage-hair hypoplasia. And here we had some, can't remember how many patients we had, but fibroblast cultures, and we did transcriptome analysis and identified 130 downregulated genes in cartilage-hair hypoplasia fibroblasts. And we could show that these downregulated genes were significantly connected to the cell cycle, but there are many other pathways involved in, for example, regulation of apoptosis, bone and cartilage formation, lymphocyte function, and as well this PI3K signaling cascade. So many findings, but maybe the main finding was, which was also confirmed and has been shown in some other studies as well, that the cell cycle progression is defective in cartilage-hair hypoplasia, and it's especially this G2 phase leading to mitosis, which was longer than normally. And it's been already many years back been speculated that there could be a generalized defect in cell proliferation, and this could then explain many of these clinical features depending on which cell lineage is affected, leading to these manifestations like growth failure, hair hypoplasia, anemia, impaired immunity, Hirschsprung disease, and we've also showed that the males have impaired spermatogenesis. So maybe this is functionally the main finding. So we then focus on growth in cartilage-hair hypoplasia. Some very old studies actually showed biopsies of the growth plate, human growth plate in cartilage-hair hypoplasia, and they showed that the chondrocyte columns are completely disorganized. And this is a more recent study studying in mice the expression of this RMRP RNA and also the protein components of this RNase MRP complex, and they were able to show that they are expressed especially in the hypertrophic chondrocytes in the growth plate. So there is a defective growth plate function in cartilage-hair hypoplasia, and this leads to impaired growth, but also to these abnormal metaphyseal changes in the growth plates on radiographs. And what is then the growth pattern? We know from pediatric endocrinology that the growth is extremely rapid immediately after birth, during the first weeks of life, and then again after or during puberty, when there is a growth spurt. And these are exactly the times when the growth deviates from normal in cartilage-hair hypoplasia. And this is from our old study from 30 years back, showing relative height in a large cohort of Finnish patients with cartilage-hair hypoplasia. So the patients already have a mild short stature at birth, and then during the first year, there is a rapid deceleration of the growth, and a deviation from normal curves goes quite steadily around the 5 SD curve. And then there is a further progression around puberty, when there should be a pubertal growth spurt. So already at birth, the patients are relatively short. Adult height is both in males and females approximately minus 7.9 SDS, and I've given the values here in centimeters, and I tried to calculate in feet and inches. Hopefully they are correct. But males are a little bit taller than females, and these are the growth curves, normal plus and minus 2 SD curves, and the CHH curves for males and females here below. And these are, as I mentioned, quite old, but still valid today. So the patients are short, but they also have disproportionate short statures, meaning that they have short limbs. The spine is usually very mildly affected, meaning that the spine is quite long, and the head circumference is normal. Regarding the orthopedic aspects, this is not really, especially when we are comparing with dystrophic dysplasia, the patients don't usually have any major orthopedic problems. We don't have any very good studies from our patient population, but this is one that has been reported from US patients, including a large number of patients. And the main finding was maybe that there are many typical features, especially the varus deformity of tibia and the ankle varus deformity. And they mentioned that surgical alignment of lower limbs was performed in 43% of the patients by young adulthood. But there are not really very many other orthopedic studies, but that's our impression as well among our patients, that the varus deformity is the main problem. Regarding the hair hypoplasia, that is a typical feature, but extremely variable. And these are patients from a Brazilian publication, photographs showing that there is really variability from almost complete alopecia to completely normal hair. And there is actually, in OMIM, there is a separate entity for this type of cartilage-hair hypoplasia, where there are only skeletal features, but the hair is completely normal, and there are no signs of immune deficiency. And this has been regarded as a separate entity. But actually, nothing is known about the prognosis. These are children that have been reported. And so we, in our Finnish cohort, we then decided to look more carefully into the prognosis in patients with normal hair. So among the 80 Finnish patients with cartilage-hair hypoplasia, we identified 10 who had completely normal hair and absent exoskeletal manifestations in childhood. So they didn't have any infections or immune deficiency. So what happened with these 10 patients, actually 8 of them later than in adulthood developed extraskeletal manifestations, and 2 of them developed malignancy, 1 Hodgkin lymphoma and 1 neuroendocrine carcinoma, and then 6 others developed signs of immune deficiency with recurrent infections and bronchiectasis. So really poor prognosis, and it seems that the normal hair does not protect from all these complications. And our conclusion was that all patients with these RMRP mutations need to be followed carefully, even if they have if these early extraskeletal manifestations are absent. Then regarding immune deficiency, which I think is really the main problem in these patients, or for the patients. So they clinically, they often, at least half the patients have recurrent episodes of otitis, sinusitis, or pneumonia. They may develop bronchiectasis. We've seen that in a fairly large number of adult patients, and some also have fibrotic lung changes. And surprisingly, we found autoimmune diseases in 11% of the patients, very variable spectrum of those. But what is important, this immune deficiency leads to increased risk of malignancies, and we've shown in separate studies that the standardized incidence ratio for non-Hodgkin lymphoma is 90-fold compared with normal population. For skin cancers, it's 33. There are also other cancers, and these are often diagnosed in young adulthood. So we then think about the laboratory features. The most consistent findings are lymphopenia and a decreased lymphocyte proliferation response. But there are also, we measure T and B cell lymphocyte subclasses. There are some specific changes, but they seem to be very variable, and also in one single individual, the values may fluctuate, and overall seem to correlate relatively poorly with clinical manifestations, especially these just normal lymphopenia and decreased lymphocyte proliferation responses, which are present in most of the patients. And now, most recently, we've done this study to really look into these predictive laboratory values in a cohort of patients who were born after 2000, and that's because we wanted to focus on individuals who had more careful immunological evaluations, and also these lymphocyte subclasses had been measured. And so this figure shows how the patients are organized based on severity of T cell laboratory abnormalities. So these are the most severe findings with low CD3 positive and low naive CD4 positive values, and abnormal stimulatory responses. So different grades, and you can see that, for example, the birth length, which this purple dot means that the birth length was below -4 SDS. So the patients tended to be shorter. They more often had Hirschsprung disease. They had very often anemia requiring transfusions, and they had some other recurrent otitis media. Some had autoimmune disorders, otitis media. So quite a lot of problems accumulated in this group of patients over the years. So maybe these T cell values really have a predictive value. But we've also done this study to look prospectively what is the prognosis of the disorder, and this is actually based on my early studies when I was doing my PhD work in 1992. So this is one of the publications. So we had 107 patients, and here you can see the age distribution or year of birth for these patients recruited at that time. And already then we were wondering how come we did not identify any patients above the age of 51 years. So now we went back to this initial cohort, and we chose 80 of those patients for whom we had could find the consent for the study. So we collected data over the years from hospitals, from national medical databases, and cause of death registry for 80 patients. And primary outcome was immunodeficiency-related death, including death from infections, lung disease, and malignancy. And then we also calculated the standardized mortality ratios. We did not have very good immunological parameters for these patients, so we used a clinical classification of immune deficiency, so that they were classified into 3 groups: asymptomatic immune deficiency, meaning no increased infections, humoral immunodeficiency, recurrent respiratory tract infections or sepsis, and then combined immune deficiency, the most severe presentation. And we determined this separately for childhood, adulthood, and then end of follow-up. So 80 subjects, mean age at baseline 92 was 14.6 years, and median follow-up now was approximately 30 years for the surviving patients. And we knew the genotypes. Most were homozygous for the major mutation, but then some other mutations were also present, and none of these patients had undergone hematopoietic stem cell transplantation. So this is a little bit busy slide, but it shows the course of immune deficiency from childhood, adulthood, and end of follow-up. And so we had 57 who manifested no symptoms of immune deficiency during the follow-up, so they remained asymptomatic. And then some switched to different groups, and 24 had symptoms of combined immune deficiency. And you can also see that quite many of the patients had disease, 16 in adulthood and 2 already before adulthood. And if we then focus on the ones who had asymptomatic immune deficiency in childhood, so 52 individuals altogether. And when we look at end of follow-up, we could see that only 34 of these 52 patients were alive, didn't have a cancer, and didn't have symptoms of immune deficiency. And actually 15 of them had been diagnosed with cancer, and 4 of them had already deceased from their disease. And then 4 others had died of immune deficiency unrelated causes. So even for those with asymptomatic immune deficiency in childhood, the prognosis was really, really poor. And we could also show that cancer-free survival, so the patients remained without cancer, was poorest for those with combined immune deficiency in childhood. Regarding the malignancies, altogether 25 of the 80 patients. So 31% of the patients had been diagnosed with a malignancy. Lymphomas in 9 patients, and actually 5 had poor prognosis and they had deceased of lymphoma, while there were 4 survivors. And what was important, we could see that all these had a scheduled follow-up for monitoring with ultrasound, for example, or they were evaluated after very mild symptoms for a suspicion of lymphoma. There were 6 patients with other types of cancers listed here, and then skin cancers in 15 patients. Mortality overall was 7-fold compared to a normal population, and as you can see here in the age group of 45 to 74 years, it was 65. The standardized mortality ratio, and this of course explains why we did not find surviving older adults in our initial recruitment. Here is a distribution of the mortality courses across different ages, so infections early on, but then malignancies and lung disease with this bronchiectasis. And we could here show that the birth length ST score correlated with age at diagnosis of first malignancy and age at lymphoma diagnosis, and also age at diagnosis of first skin cancer. So this is age at first malignancy and versus birth length. So the severe disease early on seems to predict a severe disease course. So to summarize just this immune deficiency part, there seems to be a really extremely variable pattern of disease course. There are a lot of malignancies, and premature death is common. And what is really important to keep in mind that clinically asymptomatic immune deficiency may progress and lead to combined immune deficiency later on and malignancy. Patients with this combined immune deficiency have the poorest prognosis, and this group definitely probably benefits from early interventions like hematopoietic stem cell transplantation. And then this lung disease is an important cause of death in adults. So regular follow-up is indicated in all patients. Just a few words about hematopoietic stem cell transplantation. We now have experience on some, but they have not been summarized and have not been reported. So I'm just summarizing the other cases that have been performed in other centers. In the literature, approximately 40 cases of hematopoietic stem cell transplantations in cartilage-hair hypoplasia. The survival rate is high, 76%, but there have been some deaths related to severe infections and graft versus host disease. But it's been shown that the maturity restore normal immunity after transplantation. But of course, it takes a long time to really show whether this has an effect on risk of malignancies in these patients. So maybe this is a treatment option for patients with cartilage-hair hypoplasia and severe combined immune deficiency, but maybe also in milder forms. And there needs to be some kind of international consensus of criteria for these transplantations. And I showed this figure, but here I just like to point out that quite many of our patients have been transplanted now. The red arrows indicate, and it's especially these patients with severe T-cell problem that have been transplanted. So to conclude, CHH is really a pleiotropic skeletal dysplasia, and the severity is greatly variable. The clinical course is also very unpredictable, and there are a lot of immune deficiency related complications and increased mortality due to malignancies especially. So the patients, regardless of severity and the phenotypic presentation, they need careful follow-up. These transplantations are indicated in at least some patients, but of course more research is needed to really improve patient care and define the criteria for hematopoietic stem cell transplantations. Thank you, and I'll be happy to take any questions before we take the cases.